Hello, 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 hello. How are you doing? How are you doing? Are we ready? Now, if you've got any questions that you want to go ahead and ask me, just go ahead and put them right there in that chat box. A couple of people emailed me some questions earlier, so I am all ready to go. I want to welcome you to our YouTube live event, Ask the WOCN. My name is Joy Hooper, and I am thrilled to be here today. You know, ostomy surgery can be necessary due to multiple conditions. And many times patients forget what they've learned in the hospital or their needs change once they get home from the hospital. Well, I'm here today to explain some basic ostomy surgeries. I'm also going to look at some different ostomy supplies and some common peristomal skin complications as well. But before I get going, I would like to thank our sponsor, Shield Healthcare. Shield is an industry leader in providing incontinence, urological, ostomy, enteral nutrition, wound, and diabetes supplies to the customers right at home. And with serving the customers for almost 60 years, Shield is recognized for its commitment to patient and caregiver education. On their community sites, you can find that at shieldhealthcare.com. Shield has more than 2,100 educational articles, videos, and lifestyle resources. And their YouTube site that actually houses most of their video content has over 2.2 million views. So if you haven't done so already, please follow Shield's Ostomy Life on Facebook. It is a great active community for ostomates. Before I start, I want to address something that's got us all concerned right now. That's the coronavirus. So we reached out to the United Ostomy Associations of America and spoke directly with Susan Burns. And Susan gave us a statement from the UOAA with their recommendation. And what the UOAA recommends is that all individuals consult with their own primary care physicians as well as the Centers for Disease Control, the CDC, for actual up-to-date information. They recognize that many people that have ostomies and continent diversions are older people. And there are also people that have chronic disease, and they are going to be at a higher risk of developing a serious illness. So please, let's make sure that we are checking with the CDC guidelines for people who are at risk. And also, if you need some online resources for contact with a WOCN nurse, because right now we are doing a lot of telehealth, there is a new app that just came out in February. It's Ostomy 101. It's a free app. And in that app, you can have access to make an appointment and have a one-on-one chat with a ostomy clinician. So again, that's Ostomy 101. And then there is also a WOC nurse who is online at anitanurse.com, ANITANURSE.com, anitanurse.com. Okay, so that is out of the way. I want to begin right now, and the first thing that I want to do is I want to explain digestion to you. I'm going to go through the GI tract, talk about what each part does, because it's very important that you understand that as we discuss the different types of surgeries. All right, you chew your food, it goes down your esophagus and into your stomach. When the food is in the stomach, it's met with digestive enzymes. It's churned up into a liquid. It's held in the stomach, and then it's slowly released to go into the small intestine. Now, as that chewed up food goes into the small intestine, the pancreas, the liver, the gallbladder, they all add in additional digestive enzymes to continue breaking that food down and to continue breaking that food down as it passes through there. And it's got to be really broken down because it's the walls of the small intestine that absorb the vitamins and nutrients out of that chewed up food and take it to be used for fuel for our bodies. So we can say the small intestine eats for us. And since the digestion is happening there in the small intestine, you've got to understand what a caustic environment it is. I mean, think about it. If it can melt down a steak, if it can melt down cabbage, that's pretty doggone caustic. That's because those digestive enzymes, they know their stuff. Digestive enzymes know how to digest. That's basically all they know how to do. Once those digestive enzymes get out of the GI tract and onto the skin, all they would do is digest the skin. So we want them staying where they're supposed to be. All right, now once that chewed up food moves through the small intestine, it's going to enter into the large intestine, also known as the colon. And as the small intestine ate for us, the large intestine, or the colon, is going to drink for us. It's going to do that by absorbing the liquid that we drink and the liquid from the food that we eat. It's going to be absorbing that. So your content is going to get thicker and thicker and thicker as it travels through the colon and then exits your body through your anus. First one I want to talk about is a colostomy. Now, a colostomy, it's called that colostomy because it happens in the colon, the large intestine, and it can be anywhere in the large intestine. When they do the surgery, they try to leave the patient with as much large intestine for absorption as possible. So what the surgeon's going to do is separate the GI tract, just like I've separated it right here. Now, they could remove this anal section and close that area up. Many times they have to do that if the person has anal cancer. Or they could leave it in place and just suture it shut, the way I've done on this apron. Now, we got to do something because we've got food going in here and we've got stool coming out here. So the surgeon is going to create a diversion. The way that they're going to do that, on the outside of the abdomen, they're going to make a small incision. See, I made this incision. Then they're going to bring that open end of the GI tract out and fold it down. Let me get close. Out and fold it down. There you go. You see what I did? And create the stoma. That's what this is. And then the person is going to wear a pouch over this, and their stool is going to go into the pouch. Now, the stool that comes out of a stoma from a colostomy that's low over here on the left side, that stool would be very similar to what that person would have had prior to their surgery. So it's thick, it's typically formed output. All right, that is a colostomy. Now with a colostomy, the person can wear a drainable pouch, the one that you would wear a clamp with, or the one that has Velcro, or the person with a colostomy can use a closed-ended pouch. Because the output from a colostomy, like I said, it's more solid, and there typically isn't going to be as much as the person with an ileostomy or a urostomy is going to have. And by the way, another option that the person with a colostomy might have is called colostomy irrigation. And colostomy irrigation is kind of like giving the stoma an enema, and the person will just wear a tiny little stoma cap, a little cover over their stomach. They don't have to wear a traditional pouch. All right, that was a colostomy happening in the colon. Now, let's talk about what would happen if the person had their colon removed, or if it had to be bypassed. Well, if it had to be removed or bypassed, that's going to leave us with the small intestine. Now, do you see with the small intestine, I have no colon drinking for me anymore. That means my small intestine and my stomach are going to have to pick up the slack. And if they don't do it, the person is going to be in the hospital with dehydration. It is as simple as that. So the person is going to have to drink extra fluids to help the stomach, help the small intestine pick up the slack. All right, so now I've got the ileum of the small intestine separated from the body, and I am going to make an ileostomy stoma. Here I come. I'm doing the same procedure, bringing it out, folding it down onto the body. Now look at this stoma. This stoma is smaller right here, and that's because it came from the small intestine. And the small intestine has a much smaller diameter than the large intestine. The person with an ileostomy is going to wear a drainable pouch because their output is going to be more liquid. They're going to be emptying that pouch several times a day, and some people even get up at night and empty. Now, colostomy irrigation would not be an option for the person with an ileostomy because there's really not a way to regulate that. For the person with an ileostomy, we want to make sure that they're chewing their food very, very well, because ileostomies are more likely to have that bowel obstruction or that blockage than a colostomy will. All right, so the output from this one, not only going to be really liquid, but since it's coming from the small intestine and the small intestine does the digesting for us, that output is going to be caustic, very, very caustic. So what we want is the person with the ileostomy, if they feel any burning, any itching, any weird sensation up underneath that stoma, they need to change that pouch because there can be leakage up underneath that pouch. And what that leakage is going to be is digestive enzymes. And like I said, all they know how to do is digest. And if they can digest that steak in my stomach, they can digest my skin like it is butter. I mean, it won't be any problem for them. All right, that is a colostomy. Now let me put myself back together and I want to show you what a urostomy is. Now, with a urostomy, of course, we're going to be talking about urine. So let me pop me on a couple of kidneys right here. Now, I am just throwing these kidneys right on my body because it's convenient for me to put them on the front. Your kidneys are actually closer to the back of you, and you know, they're behind the GI tract, but I can't do this presentation like this, so I just throw them right here on the front. I've got my kidneys, I've got my ureters, I have got my bladder, and I've got my urethra. Now, to be honest, this urethra right here is nothing but an educational urethra. If this was a real urethra and it was mine, it's going to be really, really short. And if this was a man's urethra, well, it would need to be a great deal longer than I'm looking at right here. So this is just an idea of explaining what a urethra is. Now, when somebody typically what they're going to do is remove the person's bladder. Now, when they do that, yes, they could bring the ureters out and make ureterostomies. But you know what? The ureters don't make good stomas. They're small. Number one, they are so very small. But also, when they create stomas out of them, those stomas tend to stenose. What I mean by that is they get smaller and then they harden. So they don't make good stomas. So usually what the surgeon is going to do is go back to the small intestine and they're going to remove a little piece of the ileum. Now the ileum was that last section of the small intestine, the one they make the ileostomy out of. Well, they're going to remove or separate a little small piece of the ileum, and they're going to make a conduit out of it. Now, a conduit is something that carries something from one place to another. Well, in this case, the ileum is going to be the conduit that carries the urine from the ureters out of the body. So what they're going to do is they're going to close off one of the ends of this little piece of ileum, and then they're going to implant the ureters into that section of the ileum. You see, I've got them implanted in there. And then you probably guessed this part. They are going to do that same stoma procedure where they bring the open end of that ileum section of the GI tract out through the abdominal wall. And now the urine is going to drain from the kidneys down the ureters into this little ileal conduit section and then exit my body. And I'll be wearing a urostomy pouch to collect this urine. Now, the person with the urostomy needs to wear that drainable pouch. They will be emptying multiple times during the day. And most of the time they're emptying at night as well. That's why many people that have a urostomy use some type of nighttime drainage collection device. Okay, so that was a urostomy or ileal conduit. And did you notice when the person has urostomy surgery, they're not only having surgery on their urinary system, you know, this was surgery on their GI tract as well, because they had that little piece of ileum removed. Okay, let me take that off. One of the stomas, the most common stoma, and it's the one that I have made with my aprons, that's called an end stoma, E-N-D, an end stoma. Easy way to remember it, they bring the end of the GI tract out through the abdominal wall. Then what they do is fold it over and they suture it down to the body. Yeah, that's what they do. Suture it down to the body. That is your end stoma. It's got one opening in it, an end stoma. Yeah, we like it when it protrudes off the body. Yeah, we do. We do. Okay, now there's another type of stoma, and we see these stomas frequently done in temporary procedures, but we also see them in abdomens that have larger girths, you know, our bigger abdomens. That's a loop stoma. With a loop stoma, the surgeon is going to, let's say this is the outer abdominal wall, they're going to pull a loop of the GI tract up onto the abdominal wall, and they typically put a rod or some type of stabilizer in it to hold it up over the abdominal surface. Now, to allow the output to come out, they're going to make a split in this piece of colon and then, or GI tract, and then they're going to fold it back on itself. Now, did you see when I folded it back like that, the back wall came up and separated it? You can see I've got two openings. I've got an opening that goes toward the front. So this is where the stool would come out. And then I've got an opening that would go on to the distal or the final kinds of different ways. As a matter of fact, all stomas look different, but I really see more variation with the loops. Sometimes you can see both opening. Sometimes you can see one opening. Sometimes you can't see a thing. And then sometimes surgeons perfect them a little bit more and they can look like a snout, or they push the two ends together like that. And you can see both openings made really, really well. One of the reasons they like to do these for temporary procedures is because when it's time to take it down or put the person back together again, all they have to do is close it back up. And that's a whole lot easier than removing the stoma, opening it back up, and sewing the GI tract back together. See, with the loop, it was never completely separated. So they like to do that one for temporary procedures. Like I said, it's just a whole lot easier to take. Some of the reasons they look different is depending on what part of the GI tract was used to make that stoma. Was it the large intestine? Was it the small intestine? Or was it that small little ureter? We don't like to see those. Well, of course, excuse me, the area of the GI tract has to do with it. Well, the surgeon's, you know, his skills, that has to do with it too. But do you know what the biggest factor or the biggest variable is going to be when we're talking about why stomas vary? It is the patient's body. And that is going to be because it depends on how much fat or adipose tissue. I like to call fat adipose tissue. It just sounds so much prettier. But it depends on how much adipose tissue we have on our body. Let me show you what I'm talking about. This adipose pad is representing maybe about 10, 15 pounds of additional fat on my body. Now, when we put fat on, you know, it builds up all over our body, and our abdomens just get bigger and bigger and bigger and bigger. Well, you know what? The GI tract stays in place. And you got to remember, your GI tract is a lot closer to your backbone than it is the skin right here on your abdomen. And then when you're building up all this adipose tissue, this fat on your body, Well, that's just more layers and layers and layers of it above your GI tract. So when they do your surgery, they've got to go through all that adipose tissue. So let's go through some of this adipose tissue and let's see what the stoma is going to look like once we've come through the adipose tissue. Well, it's not as easy to do it as it would be if I didn't have my adipose pad on. Okay, let me come around and bring this out through. Yeah, again, it's not as easy to do. And you know what? I'm getting somewhere now. Yep, I feel it. You know, it's work. It really is work. And imagine, this is just 10 or 15 pounds. Imagine if it was 300 additional pounds. That is going to make a great deal of difference in the way this stoma is going to appear. And it's also going to make a big difference in what their abdomen is going to look like. Because as I look at the stoma, I've got creases and folds in the material around my apron. Now, I could have done better with securing it, but all right, you see the creases and the folds, and look at that flat stoma right there. Yeah, that is because of the adipose tissue or the fat tissue on my body. And if you have a flush stoma, that means it's a stoma that's level with the body. If you have a flush stoma, or if you have a retracted stoma, sometimes it can be harder for you to get a seal. Most of the time, when our patients have a budded stoma, and a budded stoma is a stoma that's going to stick up over the abdomen, on top of the abdomen, those are great because what it will allow is into the pouch. And that is usually going to be a lot easier to get a seal around than if you stoma. They would use the backing of their skin barrier, also known as a wafer. They would use one that's flat. Do you see how that is a flat surface right there? That's flat. But for the person that had recommend that they use something called convexity. And there we go. It's bowl shaped on the back. What that is going to do is it's going to push down on the skin that's around the stoma and encourage the stoma to perch up or poke out, protrude, whatever you want to call it, as much as possible. And the more it protrudes and allows the output to fall into the pouch, usually the easier it's going to be to manage that output. Now, for years, these were the only two types of contours that we had on the backs of our skin barriers. We had flat and we had convexity, but now another one has entered into the game, and that is something called a convex flip. And this, when it comes to you, it's shaped like that, so it looks convex. You have a hernia, you have loops of intestine that have gotten trapped in an area where they're not supposed to be, and you end up with a large bulge right there underneath your skin. And it's going to be really hard to get something flat to stick on that bulge. It literally is a curve like you're seeing the back of my hand right here. But I could take the convex flip and it would fit perfectly. So this is another contour, another option that we have only had in the last year or two. Other things, do what? Oh, okay. Let's see. Let me show you. I've shown you a couple of different pouches. These are one-piece pouches right here. I've got both a flat and I've got a convex. One piece. The product is made together as one piece. And this is a two-piece, just as the name implies. Two pieces that get snapped together and make one pouch. Now you notice this pouch is clear. That's an option. In the hospital, you're going to have a clear pouch because we want to see that output and we want to keep an eye on that stoma. So it's really important that you have a clear pouch. However, once you get home, you may decide, I don't want to see it anymore. And you can go to one that is called opaque. With an opaque pouch, You can't see the contents. Many people like them. This happens to be an opaque pouch that's closed-ended. This would be ideal for that person that had the colostomy. And you know what? This one came to the person pre-cut, meaning the opening was pre-cut to fit the size of her stoma. And I can see that this one also has a little filter in there as well. Okay, so I've gone over the different surgeries. I have gone over, a couple of the different products. Let's see, let me go ahead and jump down here and see what questions you have got. Let me roll my chair back up here. Let's see what questions I can answer for you. Okay. All right, I'm going to start with, what do you do for pressure ulcers or a fistula just above the stoma? Well, you're going to be doing wound care there. Pressure can cause tremendous wounds on the body, and when it's in the stomal area, it's very difficult because you've got to maintain that seal. So you are going to be doing wound care if the wound actually has some depth, filling it with something like an alginate and pouching right on top of that. Now, if it's a fistula, many times that if it's a peristomal fistula, meaning it connects to the stoma, many times we cut the opening in the pouch. Sometimes you have to go to a fistula manager or a wound manager, which is a different type of ostomy pouch. It's just designed to usually hold more or allows you to cut a bigger area out. You may be needing to use one of those, Jennifer, to be able to accommodate not just the stoma, but the fistula as well. Okay. Hello. What do you do when you have a granuloma that causes leakage around the stoma? Oh, those doggone granulomas. Now, if you had a granuloma would be something they're usually developing right out here at the border where the stoma meets the skin. We actually call this the mucocutaneous junction. Yeah, and they get these little granulomas, these little bubbles of mucosal tissue that grow there. And sometimes they grow not only around here, they start to grow over the stoma themselves. Many times what we're going to do with those is you're going to need to see your WOCN nurse or your clinical prescriber to go in and remove those with a little bit of silver nitrate. Silver nitrate is a caustic substance that's going to burn them. And there shouldn't be any pain because your stoma does not have the same kind of nerve endings that transmits the pain impulse. So it shouldn't be painful, but you're going to need to have them removed so you can get a good seal again. Okay, let's see. Next question. Good. My question is, I would like to try a one-piece urostomy pouch. How do I obtain the trial one for that one-piece urostomy pouch? Kim, what I recommend that you do is that you reach out to the different manufacturers, or you could reach out to the DME where you get them and ask for a sample to trial of these. Your major manufacturers want you to try their products out. And, everybody feels like they've got the best products. And I'm going to tell you what, when you're talking about Hollister and Coloplast and Convatec, those are some awesome products. I couldn't choose one being my favorite manufacturer because I absolutely reach out to all of them. There's also Marlin, and there's New Hope, and there's SciMed as well. So we've got others besides just those big three. But reach out to the manufacturers and ask them for a sample. Call their consumer line. It's usually easy to find right there on their website. Call them and ask for a sample. That's all you got to do. They would love for you to try their products. So if you're used to a two-piece and you want to try that one piece usually is going to give you a lot more flexibility. So that would be a great thing for you to try. Okay, let's see here. Thank you very much. Let's see. Let me scroll down and see what else it has. What's the little filter on the pouch you just showed us? There you go. Is that why you handed me this? Thank you. You got me a helper today. All right. This is the little filter that I pointed out on the pouch. All right, Renee, the reason that you have a filter on here is because you know how your body emits gas? It really does. On an average, most people emit gas, poot, fart, whatever you want to say. They do it anywhere from 10 to 20 times a day. But sometimes it's such a small amount, your butt doesn't even tell your brain that it's going to just let it go. And so many times if you don't have ostomy surgery, you're none the wiser. It just leaked out. But if your output is going into a pouch, you are going to be very well aware of how much gas and how much output that you're putting out. And so your gas is going to go right into this pouch. And if it wasn't for the filter, since this is a closed-ended pouch and it's going to be sealed to the body, it would blow up like a balloon. But since there's a filter right there, the filter is going to allow the gas to escape. And this one has charcoal in the filter. So as those molecules are coming through this charcoal, it's going to neutralize the odor. So many times it lessens the odor. You have to be careful with the charcoal filter. If a charcoal filter gets wet, it's not going to neutralize that odor for you anymore. Now, not all pouches have filters. You can order a pouch with or without a filter. And sometimes a person with an ileostomy, well, when they lay down, the stool would run up to the top of the pouch and it would wet that filter and make the filter where it's inactive, doesn't work anymore. When Coloplast created their last group of pouches, that's the Mio, they added a pre-filter right here. And this pre-filter, when the person with an ileostomy is laying down, it's going to make that liquid run all the way through that pre-filter before it actually gets to the filter. So that gives some life to the filter. And then another thing that you could do is you can order a vent. There's the Chem vent, K-E-M vent, that you purchase and you would put on a pouch that didn't have a filter. You put this on after you've purchased it, and it just kind of like opening a beach ball and letting the air out. That's what you would do. You would open the vent, allow the gas to escape from your pouch, kind of help it escape, and then close the vent back up. Now that's not going to neutralize the smell, but it does get rid of the gas that's in the pouch. So that's what your filters and your vents are designed for. Okay, next question. You have occasional skin itching from your wafer, your skin every once in a while. Okay, so you've tried several different products. Let me ask you this. Have you tried not using anything except the pouch itself? By that, what I mean is many times people use accessory products. They'll use an adhesive remover to help get the pouch off. They'll use some type of skin cleanser. Then they'll use a barrier film on their body and then put the pouch on there. What I would recommend is really try and figure out, Billy, what exactly is irritating your skin? What is making you itch? So go back to the basics. Start with just nothing but your pouch, if at all possible. And another thing, when you're cleaning around your stoma, clean around it with just water. Don't use any soap. If you do use soap, make sure you're doing that when you're in the shower, because when you're in the shower, you're going to rinse it all off. But if you're just standing in front of your sink, changing your pouching system, there's a really big chance that you're not going to be rinsing all the soap away. So only use soap when you're in the shower. Rinse very, very, very well. And then when you apply your pouching system, only go with the pouching system. I would reach out to all the manufacturers, not just the big three. I also add New Hope, Marlin, Simad, and reach out to Safe and Simple as well, because the companies not only have their pouching system, they also have barrier sheets. And barrier sheet, it's just like a sheet made of the same thing the back of the skin barrier is made of. But for some reason, I've had 2 patients that could handle the skin barrier, the barrier sheet stuck to their skin, but they couldn't handle the back of the skin barrier. So we cut a hole in the barrier sheet, applied that to their skin, and then applied the skin barrier right on top of the barrier sheet. You know what? Knock on wood, it's still working really, really well. So like I said, experiment with different brands. And when I did back off the products and quit using accessories, I would just add those accessory products in one by one. And know that both your barrier sprays and your adhesive removers, you've got different kinds of formulations. You've got some that are silicone based and you've got some that are not. So make sure that you are trying all the different products. But I'm going to add this. A lot of people have issues with itching around their stoma. And unfortunately, sometimes we haven't been able to solve it. I've read articles where people say that they have itched for years. And I'm not trying to be the Debbie Downer here for you. I'm just speaking honestly. Sometimes that is just a chronic issue that we have and we've never figured it out. One thing that I think would be worth trying though for itching, and this has helped a couple of patients of mine, Hollister is our only company that has an infused barrier. And what I mean by an infused barrier is over in the UK, the backs of their skin barriers, some of them are infused with honey, some are infused with aloe. Well, here in the United States, we've got Hollister that their back of their skin barrier, and it would be this one right here, by the way, the back of their skin barrier is infused with this lipid type material called Cera. And the Cera can be very, very conditioning for our skin. You know, the Cera is in our skin. The ceramide is in our skin. And I think that would be worth a try for you as well. Okay, so start out with that one. Call Hollister, tell them you're itching, and ask for a sample. Okay, do that. And I certainly hope it works for you. Okay, now let me find my clicker. I keep closing it up. Okay. As far as providing the best adhesion as possible when replacing a new pouch over the stoma, what's the rationale for avoiding the use of peri wipes or cleaning in the peristomal area? It can be a couple of things. As far as the cleaning wipes, we're talking about what brand of cleaning wipes are you using. You know, if you're grabbing the off-the-counter baby wipes, they are so convenient to use. You just pull them out, you use them, and you throw them away. The problem is most baby wipes are infused with a product to condition that little baby's bottom. That could be vitamin E. It might be aloe. It might be shea butter. Who knows? But it's a conditioning additive to condition that baby's bottom. Well, that conditioning additive that they've added in there can cause problems with the next pouch sticking. So that's why we are so picky about the wipes that you want to clean with. We recommend wipes that are intended to be used to clean that peristomal area because these wipes aren't going to have any of those additives in there. And another thing that irritates the skin is fragrance. Yeah, I know you want that fragrant smell there, but you know, fragrances can ring around a stoma, and why we shy away from products with fragrances in them. And what about cleaning that peristomal wipes for cleaning it? Did I get that, Katie? Did I answer everything for you? If I didn't, come back and hit me up again. Hit me up again. All right, so now we've got Rona. What do you suggest when someone has real breakdown, raw skin around the stoma, and now you've got to stick an adhesive there to it? I'm going to show you a little trick. This little trick is called crusting. Can I please have a couple of paper towels over here because I will make a mess. Let me show you how to do crusting. Now for crusting, you're going to need a bottle of stoma powder, and you're going to need some type of barrier film. And you want to use a barrier film that does not have any alcohol in it, all right? Because this can really, really burn that person's skin if it's got alcohol in it, because their skin is already raw to start with. All right, the first thing that you're going to do crusting, just as the name implies, you're going to build a crust on the skin. So I'm going to start with my powder, and I'm going to put it all over the area where I want to build my crust. Now you're going to spread that powder around. And when I say put the powder down there, you know, it's not like you're flouring a chicken that you're going to fry. This is about how much powder you would want. And then you are going to take your barrier film. I've got me a barrier film right here. And I'm actually going to open this up and fold it backwards on itself. And that's going to give me some dabbing potential. Dab, dab, dab. That's what I'm going to do. And I just lost it right there. All right, now I'm going to come back and I'm going to dab this area to moisten this. This product right here, this barrier film, it is just what it says. Oh, let me get it up here. A barrier film. What this is going to do is it's putting down a layer of like plastic on top of my powder. Yeah. Now, if I had a spray, that would be a whole lot easier to use. I'm going to allow that to dry. Now, I'm actually sticking my hand in front of a little fan, so it's going to dry it faster. All right. You can see that it's built up some crust on my skin. I'm not able to wipe it off. I'm a 2-layer crusting girl. I am. Some people do 3 or 4 layers. That's what I did was I put my powder on there. I'm going to spread it out again. Now I'm going to get my barrier wipe, and I'm actually going to open up another one. Boy, this one is very, very tacky. Oh. There we go. So I'm just dabbing, dabbing, dabbing it on there. And again, like I said, if I had a spray, and usually the sprays are going to be the pump type sprays that work best for this rather than the aerosol. If I had the spray, I would just be spraying it on there and it would be a whole lot easier to do. But I always teach how to crust with these little wipes, because if you can crust with these little wipes, you can certainly do it with that lollipop, or you can do it with the spray. Okay, so let me get this off of here before I make a mess. Here we go. I'm going to let that dry. Now, what that crust is going to do is it is really going to help me out, because when you've got raw skin, your pouch does not want to stay. I need a washcloth, please, a wet one, because when your skin is raw, your pouch does not want to stick to it. You know, the adhesives that are on the backs of our pouching systems have what's called dry tack. Dry tack. What that means is it likes to stick to dry areas. It doesn't like to stick to something wet. You know, when you chew your gum, the gum doesn't stick to your teeth. Well, that's because your teeth are wet. But if you spit that piece of gum out onto the floor and then you step on it, guess what? It is going to stick to your shoe. And that's because the gum has dry tack. Well, these products are the same way. They have dry tack. So they stick to dry areas, but they don't stick to wet areas, like raw areas on your skin. All right. So I've made my crust. And look at that. That crust didn't want to come off. Protect that raw skin. My pouching system will stick to this crust, but the good and while it's stuck to that crust, it's going to allow that raw skin to heal up underneath the crust. That skin heals by a process called re-epithelialization. Those little edges of that raw area just send out epithelial cells to cover up that raw part. Okay, and it's going to be able to do that up underneath this crust. The great thing is when you remove your pouching system, it's going to lift up that crust. and it's not going to interfere with that new epithelialized tissue that you've grown over that wound that you had. All right, so that is crusting, and that is what I would recommend that you do whenever you have any raw areas up underneath your skin barrier or up underneath your wafer. I hope that helps. Now, whenever you do crusting, choose a skin barrier film that is non-alcohol. That's going to be very important for you, because if you don't, like I said, it is going to set you on fire. Okay, I certainly hope that helps. Okay, let's go to another one. And okay, here's another one. You like to swim, but the barrier is very hard to remove when wet. So what about some tips for swimming with a colostomy? Okay, I've got a couple of different tips. There are something called flange extenders, hydrocolloid flange extenders. These are crescent strips that can go out here on the outer areas of your skin barrier. It can go on a 1-piece or a 2-piece pouch. You could completely encircle the skin barrier with that. The Aqua Seal or the Sure Seal, AQUASEAL, SURESEAL. And there's another one, but it doesn't come to mind right now. And that is a transparent film that goes and covers over the skin barrier area, and it waterproofs it with that waterproof film. And the film that I'm talking about, it's similar to the product Tegaderm, that's like saran wrap, that's sticky on one side. Many times we get them over our IVs to help protect our IVs. That would be a product that I would look into as well. And then there's also a pouch that's out on the market that uses a lot of that kind of Tegaderm product, except it's called Microskin, and that would be the company CYMED, CYMED. Okay, I hope that helps, because I want you to swim. Those of us that like to swim, we want to swim. We want to swim. Okay, after soaping anybody, washing is complete. Is it a safe idea to remove the pouch during the shower to give the irritated skin on the peristomal area a good oh, yes. Okay, I bet it feels really good to take that pouch off and get in the shower and clean that skin around the stoma. That skin that's always trapped up underneath the skin barrier. Absolutely. You can take your skin barrier off. You can shower and wash that area really good. Now, don't use a soap that's going to leave a residue on the skin. Leave something that's going to rinse you clean, and clean that area really good. Rinse it off, and then get out, dry it, and put back on your pouching system. I bet that feels really good, really good. Okay. All right. How about any more questions? Did I miss anything? Let's see. I got the granuloma question. Moderator, if I have missed any questions, would you please add them in down there at the bottom for me? I think I went over the filter. Do make sure that you check with Shield's Ostomy Life on Facebook. As I said before, that is a wonderful community for our ostomates to connect with. And let me go ahead and answer the questions that I had sent in earlier. One of them was about a hernia, and she said her pouching system wasn't fitting her anymore, that since she had developed a hernia. Don't forget this product right here called the Convex Flip. So it's going to accommodate that curve or that contour that the body can have after you have a hernia. Another question was, how often do I need to change my bag? Well, typically people change their pouches on a routine basis. We don't recommend that you wait to change your pouch until it leaks. The reason that we don't recommend that is you could have erosion. You know, sometimes you have leakage behind your skin barrier, and it can just sit there. And when it sits there, it starts to melt down the back of the skin barrier, and that holds moisture, and that moisture is held right up against your skin. That can cause skin breakdown. So we recommend you change your pouch on a regular basis. Most people change about 2 times a week. So whatever is going to be the most convenient for you. Okay, Joy, can you please stand up and show off your apron? I will be glad to. I will be glad to. This is the anatomical apron that I created, and I created this several years ago. I think I made the first one like in 2003, and I made it to teach one man about his ostomy surgery. He was really depressed. He didn't want to hear anything that I had to say, and so I had to figure out a way to shock and awe him, and I made this apron. My mom helped me make the very first one. I had safety pins and staples in the first one, but she took the bottom off and sewed me these little, it looked like arms that came across the front of it, and helped me make my first teaching tool. And since that time, we've patented it, and we sell these all over the world to nurses and nursing homes, nursing schools. My website is apronsbyjoy.com. Okay, do we have any more questions? Do what? One more question. Okay. I'm able to improvise a system that minimizes pancaking. Where do I send my suggestions so the manufacturers can improve or enhance it? Nanette, have you tried reaching out directly to any of the manufacturers? If you have not, Nanette, you're welcome to email me, and I promise I'm not going to steal your idea, but I have invented and patented a product myself. I might could give you some hints on it. My email is joy@apronsbyjoy.com. It's on my website. It's pretty easy to find me. I think you could probably search Ostomy Joy and Apron, and it's going to take you to apronsbyjoy.com. But if you will email me, Nanette, we'll communicate on this, and I'll be glad to see if I can help you. No response from them? Well, you know what? Email me, and let's talk about this, okay? I am thrilled when people invent something or come up with a new way. You know, so many things in the ostomy community have been invented because of a need. Somebody has a need, and you, my dear, apparently had the need to stop the pancaking. And pancaking happens when the stool comes out of your body and it won't go into the pouch. It's like there's an invisible door here, and it happens because we have a vacuum. We've created a vacuum within the pouch. Okie dokie. Let's see. I think that might be about all the time that we have today. Danny, you need to throw me any information. If you do, you can just type it right on in. If not, I hope this has been helpful. Leave me a comment. Let me know if this has been helpful to you. Let me know if, don't forget, for additional resources, you've got Shield Healthcare. Don't forget that online community on Facebook, OstomyLife, Shield's OstomyLife. Unlimited resources right there for you to find. Thank you very much, Renee. Thank you very much. Oh, you use nasal spray, Nanette. A lot of people are using that. You know, you're talking about the steroid. Used to be Flonase. You're talking about that. You know what? A lot of people are using that off-label now. I absolutely appreciate you putting that there. Thank you. Thank you. All right, everybody. I have really enjoyed this. If you want me to do another one, a part 2, let Shield know. Maybe they'll have me back. I hope y'all have enjoyed this as much as I have. Y'all have a wonderful day. Bye now.